saying I first met Fevzi almost exactly 7 years ago, and as he pointed out, that is less than the average time it takes to get diagnosed with endometriosis in the UK. So another year to go on that one, eh? So Fevzi is a consultant obstetrician and gynaecologist at the Royal Free Hospital in North London, and specialises in advanced minimally invasive gynecological endoscopic surgery. I think I've
You nearly got all the way through.
I nearly did,
nearly got all the way through.
Did endoscopic surgery. Fevzi also did a 2-year senior clinical research fellowship in advanced gynecological endoscopic surgery, based at Minimal Access Therapy Training Unit and the Royal Surrey County Hospital in Guildford with the team there. So very well experienced. Fevzi is also active in the BSG, the British Society for Gynaecological Endoscopy, and founded, in fact, a trainee group as part of the BSGE to help trainee surgeons develop their skills and improve that, and is currently on the council as a board member. You're the treasurer, I believe.
Currently,
yeah. So welcome, Fevzi.
Thank you, Emma. Thanks for the invitation.
Thank you. And Clare Ewing is one of our London support group leaders.
I am.
Clare volunteered since 2017.
I have.
Yeah, so 6 years for you.
Well, it's basically 6 years since I met Fevzi and he did my operation.
Yeah,
so
there we go.
So literally to nearly a month.
Yeah, and you joined us straight after your first surgery, almost, wasn't it?
I did.
Soon afterwards.
Yeah, I did.
And you wanted to help other people, didn't you?
I did. I'd come to it. My mother and my sister both have endometriosis as well, so I knew the kind of long-term agonies of it. So yeah, I wanted to get involved really quickly, and so I did. Yeah,
brilliant.
2017 onwards.
Fantastic. Well, so Fevzi and Clare, thank you, big thank you for joining us, especially Fevzi. I know it's a particularly busy day in hospitals at the moment. As I say, what we've done is we've been compiling questions, and Claire's going to kick off with those. So we're going to start off by talking about how endometriosis affects people. Now, we don't yet know the cause of endometriosis, but Clare, do you want to kick off with your first question?
Yes, one of the questions we've been asked is, why does it only affect some people? So I suppose, why are some people not very lucky? And because we know that about 10% of women and those assigned as female at birth have it. So what do we know about the causes of it?
Yeah, so it's a very interesting phenomenon, really, why we know that some patients experience really severe symptoms and may have very minimal disease, whereas others will have quite severe disease and only experience a small amount of symptoms. So it's something that's very poorly understood in terms of why some patients have really bad symptoms and others don't. But some of it will be your perception of pain and how inflammatory responses affect your body, and that varies from individual to individual. We all made slightly differently, we all have different pain thresholds, and we know that different diseases affect people differently. But why that happens, is something that's not truly known, and is something that is quite interesting about this condition in particular. And we see it all from time to time in my own practice, where some patients have terrible disease and minimal symptoms, and vice versa. So it's something we keep on seeing time and time again.
Thank you. Now, I do know there's some exciting news about some genetics research being released tomorrow, so keep an eye on the press for a little bit of information about that as well. We can't break the embargo on that one. And so we don't know the cause, but there's different reasons and things. So should we move on to symptoms? So one of the questions is, what are the symptoms of endometriosis? So in fact, Clare and I are going to try answering that. Fevzi can laugh. So what we say, Fevzi, we say the common symptoms of endometriosis are chronic pelvic pain, painful periods, pain with bowel movements, pain when urinating, fatigue, painful sex, got pain in here, and difficulty getting pregnant. And those are the most common, or those are, what do you tend to hear? And
I mean, a lot of people obviously come to us, a lot of people that only discover that they have it when they have fertility problems. That's certainly what happened to my mum, who had, I think it's easy to have some symptoms and go, oh, this is, is this normal? Is this not? But then I think a lot of people discover when they go to get pregnant. But we have a lot of people with just severe pelvic pain a lot of the time, bleeding sometimes at times that are not on their cycle. Obviously, that's always something we have to check out, but there are quite a lot of us who have had that as a symptom. Mm-hmm. But yeah, it's usually a lot of pain, and fatigue is a really, really big one that we get an awful lot of.
Fevzi, what have we missed? What is
So I was
it?
just trying to tick all of the ones off.
Yes, quick.
I suppose one of them, which I would say, adding to that, is bloating. I hear quite a lot
Yes.
from patients. Again, it's probably relative, secondary to the bowel symptoms that we know endometriosis can cause, and that's one of the aspects that you hear quite a lot of. And also, exactly like you say, Claire, that irregular bleeding in some patients, heavy bleeding, and also pain that's not necessarily related to periods, but can be outside of the periods as well. We see quite often as well.
The bloating is a good point. Actually, when we do our endometriosis friendly employer scheme, one of the things we say in that is if you, as an employer, offer uniforms, that women may, or those with endometriosis may want to have 2 sizes, because actually they, can actually find that they change a size because of bloating. So that's a really good point.
And we also know that, for example, IBS is commonly one of the things that's misdiagnosed, and patients may have endometriosis. And again, bloating is one of those symptoms.
Yeah, brilliant.
Absolutely. We also get a lot of people, to be honest, who come with several things. Endometriosis seems to be, somebody once described it to me as the misery loves company illness, in that we have quite a lot of people who come with fibromyalgia, chronic fatigue, other things that kind of seem to interact with it, which seem to have some kind of general inflammatory response that we don't kind of understand. Something we get asked a lot, which is the most basic question, and obviously we'll go into this in more depth, is how can I control my symptoms? Because I think particularly with the pain, it is one of those things that takes over your whole day life. So what are the options starting out at the beginning of diagnosis?
So again, the way I try to think about this is broadly categorizing into different options. So one of them being your non-hormonal, more simple conservative options, and that can include things like your simple painkillers. It can include exercise, good diet, physiotherapy as basic measures, which can help significantly a lot of patients actually. And then I tend to talk about some hormonal options, and again, there can be various different types of those, both ones that can be taken orally, or ones that involve a coil, such as the Mirena coil, as an example, that can be sited in the womb lining. And then, of course, you've got more complex pain solutions. So we do have access now to pelvic pain specialists or physicians, which can prescribe, pain relief that can affect the nerves and help dampen down that process. And also nerve blocks, which can help with pelvic pain, are quite useful. And then, of course, you've got the surgical options, which we tend to talk about in terms of usefulness for diagnosing the endometriosis, proving it's there, which helps a lot of people, and then also treating it at the same time. So that's how I tend to categorize the different options. But the options are evolving and growing all the time, which is brilliant.
Yeah, absolutely. One thing that comes up a lot with us is people will say, I've been to my GP, I think I have it, I have all the symptoms. They've sent me for an ultrasound, nothing has shown up. Sometimes they sent me for an MRI and nothing has shown up, and people get very despondent and they think that's the end of the road. But that's not the end of the road, is it, for endometriosis diagnosis? Because a lot of people don't necessarily show up in those scans. So what should people do if they still think they have it and they've had those scans and nothing has shown up?
Yeah, it's a really good point, Claire. The scans are quite useful generally. What they do tell us is if you have endometriosis in the ovary called an endometrioma, or there are large deposits of endometriosis somewhere, then scans are fairly good depending on who reads them or performs them in terms of picking those aspects up. But we know that most patients who have endometriosis don't have, the very severe or significant deeply infiltrating disease. So with those, the scans don't always pick them up. We know that the scans have limitations, and endometriosis can be, quite widespread, but not be picked up. So I think if you really think you match those symptoms, as a minimum, being seen by a specialist or gynaecologist who specializes in endometriosis will be a useful step.
Yeah.
But you can, ask your GP to make a referral to, really. And a lot of the time when it gets to the stage of MRI, most GPs won't have that ability to book the MRI. So those would have to be done by secondary or tertiary care. So I think patients are entitled to, insist on us to be referred if they really think those symptoms match the condition, really. That's what I would say.
Yeah.
And one of the things that we quite often hear is if people are struggling with a diagnosis, we quite often say keep a pain and symptoms diary and take that in to speak to your doctor. Is that a helpful thing for people to do?
Absolutely, because you can always see, the relationship of the pain when it occurs and see if it matches some of the symptoms of endometriosis that we know a lot of patients encounter.
Absolutely, and that's quite useful even, I think, further down the process as well. What we say to people often is, if you can do one that includes diet or what you've been doing, or if you've done exercise, or if you've had sex, or any of those things, and if you can start tallying that up and going, what are the things that are triggering me off, then you have a much better idea when you then look at treatment and you go to talk about it, what how to manage your own kind of symptoms within that. One thing that's been mentioned, I'm going to drop it in now because it's been, as we were talking earlier about how it's quite a prominent topic at the moment, is thoracic endometriosis, which for anybody who doesn't know, obviously most endometriosis is within the kind of abdominal cavity, but there is a lot of talk now and a lot of interest suddenly in thoracic endometriosis where it goes into the diaphragm, chest wall, that kind of thing. So can you tell us a little bit more about that? How common is it, and what symptoms should people look out for if they think they have that?
Sure. I mean, again, it's something that we're learning more and more about as time goes on, and we know that endometriosis definitely can present in diaphragm or thoracic cavity for various patients, and we don't know the exact incidence of it actually at the moment. What we tend to do is try to extrapolate from the most common presentations of thoracic endometriosis that patients encounter. And one of the most common presentations is something called a pneumothorax. It's when you can have air that gets into your chest cavity at the time of the period because of the endometriosis deposits. We know that presents in about 80% of the cases of thoracic endometriosis, and about 1,000 patients a year, or female patients a year, have pneumothoraces. And we know that about 4% of those, or just over 4%, are due to endometriosis, roughly from statistical data. So it probably equates to about 70 new cases per year, roughly, of thoracic endometriosis, and that's purely an extrapolation. So we don't know the exact incidence yet, but we do know it's not the most common of all the endometriosis presentations. Still, the most common is in the pelvis. But there's still a lot we're learning about it, and patients may present, like I said, the most common presentation is they can get a pneumothorax. Sometimes there can be a little blood where those areas are, and that can be picked up on special imaging that's done. Sometimes there could be little lesions in the lung as well. But again, sometimes we don't see it. So a lot of the times when we do imaging and scans, it's not picked up. And sometimes I do several laparoscopies and you see deposits in the diaphragm. But again, it doesn't necessarily mean you need to do something about it. You've got to target your therapy and your treatment based on patient symptoms. So if it's an incidental finding, it's just something to monitor. But I think we're learning more and more as time goes on, but it's an interesting area that we're seeing more of.
Absolutely. And one thing we've been asked about, about chest pain and rib pain and stuff, and something that we find is that I remember speaking to a pain specialist about this, and they said, there's a lot of referred pain, and sometimes you're ending up with pain in ribs, but what it actually is that your pelvic floor is very tight, or things are, the human body is very bad at working out where pain signals are coming from. So just because people have rib pain or whatever, they shouldn't necessarily worry that they have thoracic endometriosis.
Exactly. I mean, some could be bowel related, trapped wind, constipation. Different things can cause referred pain to that area, and there's lots of nerves within the pelvis and abdomen that can exactly cause that there. So that's a very valid point.
Because I think everyone now who gets like sort of pain around their ribs with endometriosis worries that they have thoracic endometriosis, but I think a lot of us get a lot of random pains here, there, and everywhere.
So it's a very small percentage that still
Yeah.
have thoracic as an overall number in terms of all the patients who are diagnosed with endometriosis. So it's still a small number.
Yeah.
I'm just going to throw a question in that we've been
Absolutely.
asked by Michelle. Is Michelle's just saying, what if we go into a bit more detail about what the symptoms are when it actually goes to your bowel? So what is it? You know, what are the symptoms that people present with bowel endometriosis?
Yeah, so thanks for that question, Michelle. I mean, I'll say it again varies. So some patients have really bad bowel disease and again don't have many symptoms, but typically it'll be pain when going to the toilet to empty your bowels. The pain may be relieved after emptying your bowels. It's very rare to see blood from the endometriosis unless it's gone all the way through into the inner lining of the bowel. Most of the time, the endometriosis starts from the outside surface of the bowel and works down. Furthermore, if the bowel is adherent to the womb, there will be, quite severe pain sometimes with periods. That's something that's quite typical of bowel endometriosis as well, because that adhesion, that inflammation in that junction, and also painful intercourse sometimes as well, is not just something that occurs outside of that, but when you've got bowel disease, you're going to have that adhesion and scar tissue in the junction between the womb, cervix, and bowel. So that's another symptom we typically see. And of course, if it gets more severe, it can be difficult going to the toilet. Some patients may think they've got constipation, but actually they may have a little narrowing of their bowel, and that could be as a result of the bowel endometriosis. So those are the common symptoms, I would say.
And so one of the things that I was trying to understand recently is that you can have endometriosis affecting the bowel directly, so it could be growing on it or maybe through, but also it's quite often it gets caught up in the whole adhesions and stuck to the womb or things like that. So even if you've got symptoms, it could be different reasons behind it, can't it?
Absolutely. So there can be growing into it, or exactly like you say, it could be attached and kinked because of the inflammations and scarring that forms as a result of that inflammation.
Oh, great, thank you.
I wanted to ask, because we get questions about this quite a lot, and a few people have written in about this. Obviously, it's taking 7 or 8 years for people to get diagnosed, but there are increasingly a lot of very young women, in fact, who are still underage, who are beginning with symptoms very early on in their periods, 14, 15. What advice do you have for people who have started periods and are experiencing very bad pain that seems abnormal at that age? What are their options?
So again, I think seeing your GP or seeing a gynaecologist who's a specialist in endometriosis, if that's what you're thinking about, is a useful first step. Obviously, we have to be careful that we are not over treating or over investigating young patients from the outset. Now, some of them definitely may have endometriosis and it may require surgery, but I think it's useful to be seen in a place which has appropriate pediatric cover and appropriate specialist gynaecologist to get that history. Start again with simple measures like we talked about with the different options for managing symptoms. And again, get the scan, see if there's anything obvious, and if there isn't, follow a similar path. Now, again, I'm not saying those patients won't require anything more or surgery, but I think starting with the simple measures, being seen by the right teams of healthcare professionals and getting the appropriate investigations is a good start.
Yeah, absolutely. Something we get asked a lot, and I think particularly because, as you know, waiting lists are very long, and a lot of people are trying to work out how they can manage things over the interim. And things that we get asked a lot about are things like TENS machines or heat. And what are TENS machines worth it? We get a lot of people who come to us saying, I've seen this TENS machine. Is it worth me investing in? What do you think?
I quite like the TENS machines, I have to be honest. I think there are some studies out there which show that there is some benefit to the TENS machine. They're fairly inexpensive now, quite accessible from online, no known significant harm with them. So I think they're quite a good investment personally as an adjunct to all the other options available to people. So I think it's something worth trying. And if it helps, fantastic. If it doesn't, you've not really lost a huge amount with it. So I think it is something I would advocate and recommend for people to try, and patients I have recommended to, quite like it actually. It's not that it's the answer alone.
No.
It's combined with everything else. I think it's a nice additional adjunct.
Absolutely. And the other thing somebody's asked here, which is the question, is it okay to relieve it with heat, or can it create problems in the long run? I think most of us have relied on heat at one point or another.
Heat again is something that's, can help. I suppose the only thing that heat can sometimes cause is some skin changes, mottling on the skin. So that's just something to be aware of. But
yeah,
if it provides you relief, there's no known significant harm other than the skin changes.
great.
And so we've got a question as well from the audience who are there today. So I've got my iPad here, so I hope looking down at the question. Are there any manual therapies available on the NHS for endometriosis? I'm presuming things like physiotherapy, so to reduce the pain from adhesions.
Physiotherapy is useful and available in most NHS hospitals, but where it may vary is not all units or trusts may have access to specific women's health or pelvic physiotherapy, which is what you really need, to someone to have some understanding of the condition, and with the pelvis in particular, rather than a general physiotherapy. So that's what I would say. I think if you're going to be referred or be seen by a physiotherapist, trying to get to one that has a specialist interest in women's health or pelvic physio.
And you have a great physio, Wilfried, don't
yeah,
you?
We're very lucky.
We have a terrific physio.
Yeah, and I believe we've got some webinars from online, so do have a look at that as well. That's great.
No, it's been really helpful. And it's weird actually, because it's something even in the private physiotherapy sector, I know that it's starting to become a real topic of interest. Even in my parents' tiny little town in Northern Ireland, there's now a private women's pelvic physio. So you kind of go, it is starting, the news is starting to spread of how helpful it can be.
And it's all those adjuncts added on to provide you with a whole nice rounded pathway of care, really.
Absolutely.
And while we're on different management, is one of the questions we've had is there any research evidence supporting the benefits of diet, such as low FODMAP diets, to manage endometriosis?
Again, diets is an interesting one. And again, we know that endometriosis can affect bowels and bowel function habits. So I think if the diet provides you with relief of your bowel function, then that's fantastic. But there's so many different diets out there now that I wouldn't say one is more favorable than the other. I think you need to try it and see what works well for you as a patient, really, and see if it helps, carry on. If not, no. But there's none that I know will work for everyone. I think it's a very individual.
We find that tragically with almost everything in endometriosis, is people will go, what should I do? And the truth is, everyone is so different. We've got people in our group who are like, I gave up weight and it's been the best thing ever happened to me, and other people have given it up and gone, it's done absolutely nothing for me whatsoever. So,
and if you like wheat, why
make your life even worse?
Exactly.
No, I think where it's just where that thing of symptom diaries and making a note of what you eat and whether you have symptoms in the day or two after that, really pays off for a lot of people, because it makes a big difference.
And then one thing somebody once said to me at a research conference was around discussion around diet, because there's not much research evidence, if any, really is there. Sadly, we would like there to be more research into this. And in fact, with Edinburgh, we did put in some bids for some research into diet and endometriosis, but we haven't yet got the money for it, but we will do one day. But around, if you've got endometriosis on the bowel and inflammation around it, it sort of makes sense that if you can soothe your bowel a bit, then it would help. But if you've got endometriosis maybe on the lining of your peritoneal lining of the pelvis, maybe it's less likely to have an impact. Do you think that's
that could well be some basis to it. It does make logical sense, but again, until we prove or try these things, we'll never know.
And more research is needed on all these areas of that one.
Very true.
So go on back to
I was going to say, moving on to the thing that everybody talks a lot about, we'll get on to surgery shortly, but the thing that most people obviously are dealing with is medical management through hormones or other. Can you give us a quick rundown of what is currently available? Because I think people come to this and they go, there are lots of options and I don't know what I should do. So what would be the order of what you would try out with somebody when they come to you with issues?
So if we're going down the hormonal
Yeah.
route. So again, it depends on what they've tried before, Claire. So some patients, a lot of the times when they come to us, they've tried different options. So some have tried the combined pill, which has estrogen and progesterone. But with the combined pill, I find that, and this is supported by evidence as well, it tends to just help in terms of reducing, say, the frequency of your periods if you take it back to back. So we commonly say back to back, and what that means is you take it with no break for, say, 3 months at a time. And what that does is mean that you don't get a period for that time. So what you're trying to do is reduce the frequency of the painful periods. And that may be okay for some people, it may work well. I tend to start with more of a progesterone only type medication because we know that estrogen is one of the things that fuels the endometriosis. So by starting with a progesterone, see if that helps. But of course, that's not for everyone. We know some people get a lot of side effects to progesterones, can affect some people's mental health. And again, it's something that you need to assess and see if that patient is suitable for that. And there are, more stronger progesterones available now as well, which some are licensed for endometriosis specifically, which can help. And then, of course, you have the coils. And again, the coils tend to work quite well for reducing periods, stopping periods in some patients. And they may have some benefit for adenomyosis as well. So it tends to be a combination, again, of estrogen progesterones or progesterone only. Now, of course, the other option that we should mention are the gonadotrophin analogues, so things like the Zoladex, neferilin, and various different types like Prostab, etc. And what they do is they switch off the ovarian axis. So they essentially stop you producing estrogen and progesterone as a reversible form of medical menopause, in a lighter term to mention it. And so what that does is reduces the inflammation of endometriosis, but it's not something that can be given long-term alone because of the effect it can have on the bones in particular, risk of things like osteoporosis. So it's something that's useful for a short period, particularly as an adjunct prior to surgery to reduce the inflammation, or some use it as a trial for a short period to see if it will help. But something long-term I wouldn't recommend personally. But those are the different spectrum, again, of hormonal medications available.
And some of those can be used in combination with each other. Like some people can get the Mirena, but they can also get something on top of that, because obviously there's some people who find that one method is not enough.
Exactly. So that is an option, but one thing that to be aware of that is some of those are off license.
Yeah.
So when using combination therapies, again, we're using it because of our knowledge of certain research trials that may have used that and deemed it safe, but as a manufacturer of that medication, they will advocate no, it mustn't be used with other hormonal options. So that's just something to bear in mind.
Yeah.
That some healthcare practitioners may be reluctant to prescribe.
Always get it from a specialist. Don't experiment on your own.
And just to clarify one point, is someone's asked, what's the maximum time you can take the combined pill back to back safely? Is there any dangerous effects of doing it for a long time? You're talking about stopping every 3 months, aren't you?
Yeah, so the reason we say to have some periods is mainly because if you're having no period, what can happen is the lining of the womb can turn a bit thickened, and sometimes the cells can turn abnormal. That doesn't just mean cancer, it can be like precancerous cells that can sometimes occur. So it's just something to bear in mind, that you do need to have periods for that reason, so that you can replenish the lining of the womb. The only exception to that is the Mirena coil. Mirena coil works a bit differently in that it causes regression of the endometrial cells, so that can be left in without having periods quite safely, and is actually used as a treatment also for some abnormal cells in the lining of the womb. So that's the only exception to that. But generally speaking, when taking back to back, I usually advocate 3 or 4 periods at least a year.
Yeah. One thing I wanted to ask, and this is a question that's come up here, but it's also a question I have. For those of us who are in perimenopausal or menopausal stage of our life, obviously there's a lot of talk about HRT. People start to get symptoms, people have worried about their bone health, whatever, people in their 40s and stuff. What is the balance to be found for people who have endometriosis with potentially starting HRT for other side effects? Is it likely to fade? Endometriosis cause other problems?
Again, that's an interesting question that we are seeing a lot of patients face, and I think a lot of patients have a lot more knowledge about HRT. There's a lot more awareness of HRT, and I think HRT should be considered by most women really because of the adverse side effects from menopause. But if you have endometriosis that's untreated or still present, then definitely by having HRT can potentially fuel that endometriosis. It can cause some inflammation. So it's important to obviously take the correct HRT, the safest preparation for you. And as a general principle, use the lowest dose that gives you benefit. Those would be my my advice to you, but also monitor your endometriosis symptoms and check that it's not getting worse again because of that. But the HRT itself is a much lower dose than what your body would naturally have been producing when you're having periods. So it shouldn't be significantly worse. But yes, it can fuel that if you're taking HRT.
It's that balancing act that everyone's always in.
There's some research being undertaken at the moment. There's a clinical trial looking at giving HRT for those in menopause at the moment, and it'd be interesting to see what results will come from that, because they're looking at what the impact is. It had to go on hold a bit because of COVID, but hopefully we'll get that back on track, so that'll be good.
That's interesting to go with. Somebody's asked here as well, if you've had your period stopped by Mirena coil or whatever, are you still able to experience pelvic pain? I think we know the answer to that, which is yes, you absolutely are. Can you tell us a little bit about why that's the case? I think a lot of people think, oh, I'll get the treatment and then because I'm not having periods, it will stop. But unfortunately, that's not always the case, is it?
So again, we don't know exactly what causes endometriosis. I mean, one of the theories is this concept of retrograde menstruation. So when you're having periods, some of the cells can go through the fallopian tubes and implant in the pelvis, Clare. But we know that that's not the only way that people can get it, because for that exact same reason that some patients have no periods, but still have the inflammation in the pelvis, still have fibrosis or deposits in the pelvis, and that can all affect your nerve fibers and still give you pain. And if you've got the coil, for example, we know some patients, unfortunately, don't get on too well with the coil. The coil can give them cramps, it can irritate the womb, because it is a foreign body, so it doesn't agree with everyone. So there's various causes as to why you may still get pain.
Yeah, absolutely. It's funny because we always, whenever anybody asks about, in our Facebook group, anybody asks about Mirena coil, it's about 50-50 people going, it's the worst thing I ever did, and 50-50 people going, it's literally saved my life. So we always just say to people, you can't know till you try these things. You just have to kind of try them out. Did you want to getting on to surgery, which is the thing obviously that people are talking about. This is there's quite a lot of questions people have asked about surgery, but one of the main ones, and I think this is a really interesting one, is laparoscopy worth having if symptoms are limited, manageable? Or if it's not for fertility reasons and you happen to be getting along, is there a problem with just leaving it there if it's not causing you? Will it spread and grow and cause you more problems? What is the best option, really?
So again, the way I look at this is, if the endometriosis hasn't caused any detrimental effect to any organ, so if it's not affecting your bowel significantly or your kidneys or anything else in the pelvis, and you can tell that from the scans that you have or the imaging or diagnostics that you have, and if it hasn't caused any detrimental effect, or it can't be seen, as it is the case from previous questions that we answered, then there's nothing wrong with leaving it alone if your symptoms are not too bad. But it is important to get that initial investigation just to check that you haven't caused any, it hasn't caused any issue in any other organ, or causing you to have any other long-term effects if left untreated. That would be what I would say.
Absolutely.
And one of the things someone's asked is about surgical intervention. And I think, again, we hear this differs very significantly person to person. So for some people, they may have one surgery, it's great, and they never need anything again. For others, the pain may return and they may need more. So I suppose what we're being asked is, after surgery, how ideally would you hope, how long would it help the patient be pain-free? Is there an ideal length or not?
I mean, with all surgery, I think it's something that has to be weighed up with, all the other options and, the risks, etc. But we do know, for example, that if endometriosis is the stimulus that's causing the pain, then by removing that stimulus and endometriosis doesn't mean the pain fibers are not still firing and giving you effects like you still have the endometriosis there. Doesn't mean it wasn't worthwhile, because obviously by removing it stops it progressing. But I think, if you're getting recurrent symptoms and surgery is only helping for a short period of time, I don't think it's the right thing necessarily to do repeated surgeries all the time, because there are risks to surgery. As good as surgery has evolved and something I love doing and enjoy thoroughly, it's not something that we advocate for every patient because of the risks. And obviously you can get adhesions and other complications which can occur as a result of it. But we do know, like we've talked before, there's several other options which supplement and complement surgery. And I think that should be something we talk about for every patient after surgery, and try those measures first before reconsidering more surgery.
Yeah, absolutely. I mean, that was literally the next question that was going to come up here. It was about, how many surgeries people can have, and would scar tissue impact? I think it's something that happens is that we know we've had a few people who've kind of come to our group who have developed endometriosis on scars, whether they're cesarean scars or whether they're surgical scars. So I suppose there's always that awareness is that the more, impact you make, the more possibility there is for kind of future. And I suppose that's one of the things that's very difficult to weigh up, and people have to do individually, what decision they make on that.
Exactly. And it's very variable. I mean, I think I can only remember one, maybe two patients where they had such aggressive endometriosis that every time you did surgery you saw several deposits. But thankfully it's not the case for most patients. Most patients, we are able to at least improve their symptoms. May not be perfect, but definitely improve symptoms with all these other measures, which I said, I really advocate every patient should have a discussion with after surgery. And if after surgery they're completely pain-free, fantastic. That's brilliant. That's what we want. But if not, all these other measures, physiotherapy, tendon machine, pelvic pain physician support should be considered, as well as hormones.
Absolutely. One question that we get asked a lot, we've had a lot of people who've told us that somebody in their past has told them that hysterectomy cures endometriosis. And as we know, there isn't a cure for endometriosis, but does a hysterectomy or an oophorectomy where the ovaries removed, does that make it less likely that endometriosis will return? And does it switch off endometriosis that's already there when that happens?
So again, that's something that's people thought in the past, and it was perceived that having a hysterectomy is a solution for endometriosis. But we know that the solution for endometriosis, obviously, to treat the endometriosis, however that may be, with surgical or non-surgical means. What a hysterectomy or oophorectomy and or both helps with is if you've got disease in those particular organs. So if you've got endometriosis on your uterus, if you've got adenomyosis, if you have endometriomas in the ovaries that are recurring, and you've completed your family and it's an option that you are comfortable and accepting of, then yes, hysterectomy may be the right thing for you in addition to treating all the other endometriosis. But it's not something that should be done in isolation in the wrong circumstances.
Yeah, absolutely.
And one of the things I know that we've touched on before is that, of course, there are drugs that mimic mimic menopause, and so they're stopping like hysterectomy. So would you always advise that first to see how that goes, or rather than?
So again, that's something that can be considered. It becomes a bit more difficult in the context of rectovaginal endometriosis. So for example, if someone has that and the uterus is very scarred and adherent to the bowel, then in those cases, it may help if there's a strong suspicion of adenomyosis and scarring in that area. But again, it's something that has to be completely individualized. There's not, one surgery that fits all.
Yeah, yet again, we find with endometriosis, there's no simple answers. It does vary depending on person to person.
Absolutely. One question we've got about surgery here is, should bowel surgeons always be present when removing rectovaginal endometriosis, or can a gynaecologist do it?
So again, another interesting question that, again, there's some variation of this worldwide as well, and even slight variation UK, but by and large, if you're doing something significant on the bowel, especially, something like a bowel resection, for example, most, if not all, UK surgeons will involve a bowel surgeon for that. Now, what we tend to say is that if there's something less invasive on the bowel, such that a bowel shave is an option, which is something we try to advocate if possible, because it leaves the bowel wall and the bowel, integrity intact, then that's something that, we do and are able to treat as gynecologists, and that's something we obviously triage, and we make that decision based on, your ability and your expertise, whether you're comfortable to do such a surgery. But even with very deep shaves, you might need a bowel surgeon there. So again, it's something individualized, but something which is, lower risk. We tend, as gynecologists, to be able to perform if we're trained appropriately and have the necessary expertise to do it with a backup colorectal surgeon if required. But for something, more advanced, then yes, it is something particularly I would do with a bowel surgeon from the beginning of the operation.
And is that the same for a urologist as well? Because obviously it's less common, but we do have some people who have endometriosis on the bladder or on ureters, and I presume that's the same kind of thing, that particularly because it's quite delicate with ureters and stuff, you kind of want somebody who's prepared to deal with that. But yeah.
Yeah, I mean, with the ureters, slightly different in that as a gynecologist, we do quite a lot of dissection around the ureters because it's the common sites where we find endometriosis. So we have quite a lot of experience in that area and dealing with the bladder. But for example, if someone has really bad disease where they need to have their ureter reimplanted or a more advanced urological reconstruction, then yes, absolutely, you're going to get a urologist involved from the beginning. And usually that's picked up with the scans if it's that severe.
And just a quick go back, someone's not understood, they're not sure what bowel shave is. And they said, so what is a bowel shave? And is it done to prevent endometriosis progressing to the bowel? Let's just say a little bit more about what it is.
Sure. So when we talk about bowel endometriosis, it can affect the different layers of the bowel. So it's a bit different to when you see a bowel specialist, for example. So when a bowel specialist sees you and they perform a colonoscopy, they're looking for abnormalities in the bowel lining, in the inner lining, things like polyps, cancers, inflammation, etc. Whereas endometriosis starts from the outside surface of the bowel and works inside. So if the endometriosis is attaching the surface of the bowel, or the most outer layers of the bowel, then what we're able to do is something called a bowel shave, where you separate the endometriosis from the surface of the bowel, but you leave the bowel wall intact because you haven't gone into those deeper layers of the bowel. But of course, if the endometriosis is more involved in the bowel wall or the muscular layers of the bowel, or deeper still, then sometimes you have to remove a section of the bowel, or a bowel resection, which is removing a portion of the bowel and joining the two ends back together again. So a bowel shave is literally removing that surface endometriosis that's attaching to the outer layer of the bowel.
Absolutely. It's Okay.
No, someone's just asked a very quick question, hopefully, which is going to be, it varies, I guess, but what's the recovery time for a laparoscopy with a bowel strain? How long is a piece of string?
I was about to say that.
So again, it completely changes. I mean, if you're doing a lot of endometriosis surgery, it may not be the bowel shave that delays. It might be the whole process of the operation and the anaesthetic, etc. It varies from person to person. If you're having a long procedure, again, it can vary how fit you are, if you have any other medical problems, any other operations previously. But generally speaking, from complex surgery, I would say most people recover 4 to 6 weeks afterwards.
I just want to bring it up because it's something that we hear a lot because people hear it mentioned to them and they freak out, which is reversible colostomies. They're not that common in practice, are they? But people hear that word and they go, oh God. But they are something that can happen with very complex bowel surgery, but they are usually completely reversible.
So yeah, so again, with colostomies, it's something that's thought about if the generally if a bowel resection occurs, and if the joint is quite close to the sphincter muscle, you want to ensure that that joint heals very well. Now, of course, when you have a bowel resection, most of the time you have a colorectal surgeon that's involved. And a lot of the times they may, have experience of doing bowel resections on more elderly patients, which may have other medical problems, and a bowel stoma temporarily may be something that's done because, if there is a leak in that joint, it can cause a lot of problems afterwards and require further operations. But again, as our knowledge and experience of endometriosis has been improving, we know that most patients that we deal with don't have many other comorbidities or medical problems. They tend to have healthy bowel, otherwise they're not cancerous bowel or have any other inflammatory bowel disease, for example. So we expect the joint to heal quite well. So thankfully, most patients now don't need a stoma, temporary stoma, but again, can't say no one ever will. And some, of course, will, depending on their circumstances. But it's not the most common aspect that
I think it's one of those things that comes up on consent. It comes up on consent forms and everyone freaks out. I think that's
and we have to make sure patients are well informed because it is a possibility, albeit a very small one.
I think that's something that comes up a lot. When people go for operations, they get bombarded with a lot of information because obviously you have to say these are the possibilities. But I think a lot of people hear that and then go, "Oh God, that's what's going to happen to me." But obviously it largely doesn't. Have you got one?
I thought we could maybe move on to endometriomas for a minute.
Oh yes.
So what is an endometrioma, Fevzi?
So an endometrioma, in simplistic terms, are really an endometriosis involving the ovary, such that you have cells on the ovary, and it fills up with, if you like, old blood within the capsule, and that has a typical appearance. That's why it used to be called the chocolate cyst, which is no longer used as much, but it had that characteristic of liquid chocolate, if you like, because that's what altered blood looks like, and it's where it can expand every time there is bleeding into that cyst capsule, and it can obviously enlarge in some patients and then cause some adhesions.
And if you have an endometrioma removed, Jenny wants to know, how likely are they to come back once they've been removed?
So we know, Jenny, that they're about 20 to 25% chance of recurrence if you've got an endometrioma. It doesn't mean it will definitely come back or it will come back to the same size, but it could be a small recurrence that can occur in about 20-25%.
Okay.
Question I was going to ask about that, related to that, because we get a lot of questions. In fact, we had one today in the Facebook group about if people are trying to preserve their fertility and they've got ovarian endometriosis.
Yeah.
Is it better to have surgery to try and basically, is the endometriosis or the surgery more likely to cause fertility loss in terms of egg reserves, and what are the best ways of preserving that?
And linked to that, is it better, so if you're trying to get pregnant, have the surgery to remove the endometrioma first or after you've tried to get pregnant? Which is a similar question.
Yes.
All of
So,
that in the
yeah.
next 3 minutes.
So yeah, definitely, removing endometriomas can affect your ovarian reserve. Unfortunately, endometriomas are quite tightly adherent to the ovarian capsule. So, even if you're the best surgeon in the world, when you're removing those cysts, it can adversely affect the ovarian reserve in some, not in all. And the reason I say that is, if you're going to have large endometriomas and treated and fertility is an issue, then in a lot of hospitals, not all, but a lot of hospitals, you can test your ovarian reserve now prior to surgery, which is something I advocate if you can do it. And what that tells you is, if you have a high reserve, it's called an AMH blood test. You know that even if you have surgery, even if it does reduce it, you're still within a good limit. If it's very low prior to surgery, then I would usually say, look, think about speaking to a fertility specialist or seeking advice from a fertility clinic prior to surgery, because there are things that can be done to try and preserve fertility. There are lots of different techniques available now. So that is something I would definitely consider. And again, whether you can try for pregnancy before, again, it depends on several factors. How long have you been trying before? Has it been effective before? Have you tried fertility treatments before and they've been unsuccessful? These will help you try and make up your mind as to whether surgery is the right thing for you before or after. What we do know is that endometriosis in the pelvis in some individuals can affect fertility, not in everyone. And in those individuals, when you have it treated or removed, it can improve fertility. But again, that's not in everyone. So again, it's something that must be individualized, but we do have a lot of tests which we can perform that can help triage and really, try and work out the most appropriate pathway for you.
And under the IVF, the NICE guidelines on fertility, it's recognised that if you have a condition like endometriosis that impacts on fertility, you should be able to access fertility support straight away and not have to go on to waiting lists. So do speak to your doctors if that's of interest. We haven't got much time left, and
I'm through most of my questions.
I've got a couple in here, so I'm trying to see another. Is someone's got some? Someone has heard that that there's a risk of endometriosis following a C-section. Can you tell us a little bit about C-sections and endometriosis and why that's a
Sure. So I suppose what that's probably referring to is we know that one of the ways that endometriosis can spread is through the concept of what we call seeding.
Mm-hmm.
So when you're obviously having a cesarean, you're going into the cavity of the womb where the endometrium is, and obviously you're then closing up the womb in different layers and then closing up the skin and the deeper layers of the muscles and rectus sheath, for example. And what we're seeing a lot of now is something called cesarean scar endometriotic nodules. So the theory is that some of those cells are being implanted in that area where you're closing the layers of the muscle and the rectus sheath and the skin, and patients can present with a painful lump close to their cesarean section scar, which can get worse during a period and can again grow, and sometimes you can remove that area close to the scar. So it's something, yes, that we've seen a lot more of over the years, and in some patients which don't even know they've got endometriosis. So again, it's something quite variable, but yes, it is something that can occur as a result of cesarean.
That's great. Now, someone's asked about the stats about infertility and endometriosis. And now I've always said, so tell me if I'm right or not, is the stat that we get told is that whilst endometriosis does impact on infertility, up to 70% of those with endometriosis will be able to get pregnant naturally, but 30% there might be an impact. Is that right? You're nodding, Fevzi.
That is right, yeah.
Yeah, so it's not, so 70% of people with endometriosis will get pregnant naturally. So, there is, for those that want to, there's hope there. But if you are struggling, then do seek help early on about that one. I've had a couple of questions around, just let me dismiss that one and I'll ask it again, around urinary symptoms. And what, are things like urgency or potentially incontinence symptoms of endometriosis, or are those other things, do you think?
So again, with all of these symptoms, I'll say yes, it's possible some of them may be due to endometriosis, but with all of these conditions, I wouldn't always assume it's definitely due to that, because sometimes you can miss other pathologies and conditions, and we're all going to get different conditions in time and as we get older. So it's really important to keep an open mind and have the appropriate investigations and speak to your healthcare professionals, be it your GP or specialists, so they can rule out these other causes of these symptoms, because some of what you describe could be a simple urinary tract infection, which is very common. So yeah, it can be something else other than endometriosis.
We were just saying this earlier. We were saying we're always very cautious to say to women, if they suddenly get a new symptom, don't just assume that it's endometriosis, because we have a tendency to assume that everything kind of fits into that. The other thing as well is that I know from somebody I know that a very tight pelvic floor can give you the feeling of urinary symptoms, that people think they have it on the bladder, but actually it turns out it's to do with their pelvic floor. So it is a bit of a try and see thing, isn't it, to try and sort of find out what the cause of that is.
Another thing just to mention on that is, the pelvis itself, the female pelvis, is not, there's so many structures in close proximity to one another, your pelvic floor, the bowel, the bladder, and it's sometimes very difficult to distinguish where these symptoms may be coming from. So a lot of these things are linked. It's just we don't always know the interactions and links of all of them.
The pain specialist told us, I remember the thing, I think it was Katie Vincent at Oxford, told us about the fact that the brain is very bad at interpreting very specific signals. So it'll go, it's somewhere in that region, but
exactly.
you may think it's a bladder thing, but it's actually a bowel, or it's a nerve, or it's a ligament.
They're so close to each
other. Yeah, the brain is kind of
difficult.
the brain is guessing a little bit, which is why people sometimes are not quite sure. They're quite shocked when they go in and they have surgery and it's something completely different from what they thought it was.
I think it's funny when you see a womb in a picture and it's nice, a nice floating womb with like a womb with like nothing around it, and then you actually look at it in reality, it's like wedged in there with bowels and bladders and things like that. So I'm going to ask one last question, because I think we need to end soon. One of the questions is it's actually linked to waiting times, and someone just is saying if they are waiting for rectovaginal surgery and they've been waiting over 18 months, is there an impact of the disease likely to progress, or what's the impact of the wait, I guess?
I mean, definitely the disease in some individuals can progress, and unfortunately the waiting times, especially at the moment, are quite long. But again, there are other things that can be considered during the wait. So, some of the hormonal medications may calm the endometriosis or the inflammation down whilst waiting for surgery, and other symptoms can hopefully be managed by, or improved somewhat with other ones. But yes, that there is a possibility of progression, unfortunately, and we do see that in some patients. But what I would say is, if you've noticed a dramatic change and you haven't seen anyone for a long period of time, you can always ask for another appointment. It may not be straight away, but you can ask for another appointment. And if further investigations or scans are required, then that can be performed, and see if your surgical date can be altered in any way.
Now,